Hi, everyone. Welcome to the Manhattan Community Board 3 Health, Seniors, Human Services, Youth Education, and Human Rights Committee meeting. My name is May. I'm the chair of the committee. So we're going to start today. We have 3 agenda items, but before the 3 main items are we're going to hear a report from Mount Sinai Beth, an update from Mount Sinai Beth Israel regarding their plan. And then we will hear a proposal about installing a kiosk for sharps at a health center on East 9th Street. And then finally, the last thing is we are going to hear from 3 service providers who are going to talk about the services they provide, and in particular, coordinating services for the homeless. Okay, so, but before we do all that, I am going to, we're going to have roll call. Oh, and before roll call, I wanted to welcome a new member. Her name is Laura Lugo. She's new to the committee, and many of you, I see her here somewhere. And yeah, so just say hello to Laura. Her. I think this is her first meeting. Okay. All right, so we will start with.
May I do have instructions for the meeting first?
Okay,
do you want to start with instruction?
Yes,
Sorry.
please.
Okay. Well, good evening and welcome to our community meeting. Please be advised tonight's meeting is being recorded. At this time, we welcome all non-board members to sign in via the chat box with your name and affiliation so we can keep track for our attendance. This evening, our chat will be used for sign-in, materials distribution, and technical assistance only. If you are experiencing any technical issues or have materials to distribute, please drop that into the chat and a facilitator will assist you with the distribution or with your technical issue. In order to reduce background noise, we ask that you please remain muted unless you are recognized to speak. Okay, thank you and welcome to the meeting.
All right, so first thing we will have a roll call and approval of the minutes. So I distributed the minutes of the last meeting, which was in July. Are there any changes or additions? If there are, please speak up now. If not, then they're approved. Okay, so I guess they are. I guess everybody is fine with it. And now we will have roll call.
Okay, good evening, everyone. I'm Thomas, the committee chair. May Lee.
Oh, yes.
Thomas, yes. Larissa?
Yes.
David? I know I saw David. Good to see you. Eric Diaz? Eric, are you with us yet? Shirley? Shirley Fantasy?
Oh, yes.
Okay, thank you, Shirley. Deborah?
Is it possible for me to abstain from the minutes or they're just approved? I haven't been here for a while, so I'm asking for a friend.
No, this is for the roll call.
Considered approved.
Okay.
Yeah, we already,
all right, well,
you're already
all
approved.
right, I'm here. Okay, fine, I'm here.
All right, thank you. Tatiana?
Yes. Hey, everyone.
Hey. Laura?
Present.
Paul? Paul Rangel, are you with us? Heidi?
Yes.
Ricky?
He wasn't planning to come today.
All right. And
And actually-
Carmen?
Oh, Carmen's going to be absent as
Got
well.
it. Thank you. That concludes our roll call.
Okay, so now we will hear our first agenda item, which is an update from Mount Sinai Beth Israel. And we have Brad Korn here to give us our update.
And I got a message that Brad Beckstrom will be joining us momentarily, but I'm happy to start. So seems like a long time ago, Mount Sinai Beth Israel had a plan to build a new footprint for our hospital on 13th Street, connecting it to 14th Street and New York Eye and Ear. And it was going to be a 70-bed hospital with space to increase in size if necessary. And I know that that was always an issue amongst members of the community and such, whether it would be enough space. Well, lo and behold, COVID hits, and there were lessons to be learned. And one of the lessons that we learned was we do need more space. And accordingly to that, and to making sure that we're serving the community the best way possible, and still keeping our main plan of, enhancing ambulatory care, enhancing care, care in the community. Instead of building the building on 13th Street and connecting it up through New York Pioneer, we have decided to figure out a way to rebuild it within the original structure at 16th Street. Now, that is somewhat preliminary insofar as that we have architects looking at it. So I don't have a plan to tell you about, and neither does the other Brad. We don't have an exact plan yet. And we obviously will continue to meet with you and work with you and discuss as we move forward. But one of the things we're looking to do in this is, we'll be upgrading the facility. We want to upgrade the emergency room. We want to upgrade the rooms. We know we have to upgrade like the HVAC, the electric systems, and a bunch of other things. But we want to be able to allow ourselves the capacity to meet the surge needs that we had during the COVID crisis. And this new plan will allow us to do so. Obviously, rebuilding while you're operating a hospital at the same time is probably going to add to our timeline, let alone the fact that, we're now getting a somewhat later start. So that's a lot of the overview, at least for Mount Sinai Beth Israel, and the main footprint of what we're looking and hoping to do. To your guys' end, first of all, it does mean that right now that 13th Street site is not being done. So you don't have to worry about the construction that might be going on there. Obviously, a lot of you who are from a little further, I guess, south, know that we continue to be working on the comprehensive center at Rivington Street, and we're moving forward with that with the timeline, I think optimistically by the end of 2022, most likely the first quarter of 2023. But nothing with that plan has really changed, and we still move forward as far as that goes. Brad, I see you shaking your head. Do you want to add into something now? To take yourself off mute. You're on mute.
There, now you can hear me. No, I think you covered it all. The only thing I would add, again, maybe the obvious, but while all this happens and plays out over the next few years, nothing changes at the current BI with regard to reduction in services, all of that.
And clearly,
It's
once
not
again,
closing.
the main message: we are not closing.
Exactly.
That's the biggest key that every time people hear this is a change of plan, and this is a change of plan that we announced back with the borough president's working group, and we've been coming out now to discuss it, but it's pretty much been met with positive vibes because it is a positive. It is something that I think people were looking forward to.
And I don't know, Brad, I was a few minutes late. Did you touch on it all? I mean, just to give a sense, the census really has remained fairly stable.
No, I didn't talk about the census,
BI,
but I mean,
like today it's 225, which is, pretty much where it normally is.
And that's
behavioral
including
health.
people in behavioral health as well.
Yep. And of the 225, we have 12 COVID patients at BI today. That has actually gone back up. There were days where BI had 0 COVID patients, but obviously with the Delta, the numbers have started to go back up, and BI has 12.
There was a time where, as a system with 8 campuses, we were down to about 5 patients, and we're back now up to over 100 system-wide, which is still far less than what we saw in the height, but it is still an increase. So if anybody on this call has not been vaccinated, we strongly suggest you get your vaccination. And now, if there are questions,
I just had a quick question. Behavioral
well, let
health.
me just add one
Okay.
thing.
Wait. We're doing the hand raising thing.
I want to just
I
add one other
haven't been
thing.
here for a while. I forget how to do
Obviously,
this.
We are committed to a open and robust planning process, working with the community. Really, we don't have anything more to tell you as far as what the structure and what it'll look like. So as we do that, obviously, we're here to talk with you and meet with you and hear what your thoughts are as we move forward. So now I'm open to questions, or we're open.
Okay, so if you have a question, raise your hand, preferably your virtual hand. I'm looking at the list. And right now, I think Susan, I guess that's Susan. Susan's hand was up first, and then after that, it's Deborah.
Okay, I have 3 questions. Are you delivering babies, and will you continue to deliver babies? I'll ask them all. 2, what changes should we expect at 14th Street now that it's not going to become the main hospital? And 3, are you continuing to work on trying to change the insurance policy for our 2 derelict insurance companies for behavioral health?
I'm going to take the first and the third, and I'm going to let Brad take the one in the middle. But right now, no, deliveries are not taking place at Beth Israel. And again, one of the reasons that moved out was not for anything other than a safety types of issues. And any program that either might return or whatever might be discussed, but everything we do, it's got to be a robust program that ensures the safety in numbers to the patients. But we obviously know that that is something that they're interested in, and we hear you and we know that. As for the insurance, we continue to fight. United's having other issues, so we're hoping that with what's going on with them, that allows that to change as soon as possible.
Okay, so with regard to 14th Street, in many ways, that's a situation similar to where we were several years ago when we started the transformation. They really are in the early stages of evaluating what options lie before New York Eye and Ear. Some of the things being discussed, parts of the services may be moved to the Beth Israel campus, but again, there's no final decisions on this. In addition, they definitely are going to be proceeding with a new ambulatory surgery center, which will be robust, state-of-the-art, new ORs, and that will be somewhere in the downtown area. They're still making those decisions, but they're really in the early stages of determining what will be done to modernize at New York Eye and Ear, what services can be consolidated, can any be moved to the Beth Israel campus. Brad, am I missing anything there?
And understanding that programmatically, a lot of what takes place in Eye and Ear work is outpatient now. It's
Exactly.
changed drastically since, forgetting about when I joined or whatever, but every day more and more things are going outpatient. So it changes the structure of how you look at the hospital there.
Yep. And there are many days at New York Eye and Ear, they only have 1 inpatient, if even that.
Wow. Okay, thank you.
Oh, so to clarify, you said a new ambulatory surgery center
Right,
somewhere
there, again,
downtown.
early-
Is that the
yep,
campus
there-
or somewhere downtown?
Somewhere downtown, likely not right on the New York Eye and Ear campus, but somewhere in that area, in the downtown area. But it would be an ambulatory surgery center for, eye, ear, and nose, whatever, eye and ear.
Oh, I see. Okay. Deborah.
Sorry, everybody. I don't know how
Hello.
to act coming back to a meeting for the first time in a while. So, I have 2 questions. So you said that there were 225 patients in the current census and 12 were COVID. How many of them are behavioral health?
I don't have it right in front of me, but usually most days it's about 70-ish are behavioral health. It fluctuates a little
It
bit.
generally
70 to
runs
80,
between 60 and
70,
70.
60 to 80. Yep.
Okay,
Yeah, 60
great,
80.
thank you. And then the second question is regarding the Rivington Street location. So you're basically continuing to plan for all of the services that you outlined at all of the meetings where you presented the things that were coming
Yep.
in, like the
Nothing
respite
has
beds
changed
and the
whatsoever
Two
at Rivington.
Right.
And the other thing you should know about Rivington is, other than we did take a small break in the height of COVID, but construction continued. It's one of the, that project was going forward, even while everything else was on a hold basis,
I know.
because there was a time that the 13th Street site was on hold just because of what was going on with COVID. We were still moving forward with the behavioral health center at
Thank
that
you.
point. Susan knows because we had to try to save a restaurant at the same time as we moved our construction forward.
I know, I'm part of the garden that's over there, so.
Okay.
I don't see any other hands
Thomas,
raised.
like he raised his hand. Thomas, did you raise your hand? No? No? Okay. Oh, went for water, okay.
Okay, so thank you.
Okay,
I don't
and as
think
Brad
we-
said, we're happy to come back at any point,
Yeah,
answer
anytime you
questions,
need
and
us,
clearly we'll
whatever-
update you when we know
Yeah,
decisions.
And obviously, as we flush this, I had preliminary discussions with Mark Levine to take over the function that Gail was doing, and he seems willing to do so. So we'll continue with the working group as well, which you guys have representation on as well. So, but anytime you want us, whether virtually or hopefully someday in person again, we will be there.
Okay, all right, okay, well, thank you very much.
Take care,
Thank you.
guys.
Have a good
Have a
night.
good holiday.
Okay, you too. All right, so we're on to our second agenda item. And is it Van Asher? Is that his name? Is that your name? I'm sorry.
Yes, hi.
Oh,
Can everyone hear
okay,
me?
yeah. So you're going to present on the proposal for the kiosk and the sharps.
Yes, and thank you. I want to thank Susan for putting me on the agenda. One of the things that I wanted to propose was having kiosks for sharps waste at a couple of locations in the Lower East Side, one of which would be in front of our health clinic at 743-749 East 9th Street. And just a little about history of kiosks on the Lower East Side. The first one was installed in 2011 in front of 25 Allen Street, which was the former location of the Lower East Side Harm Reduction Center before they merged with the Alliance for Positive Change in 2016. I first worked with that organization in 1992 when we had a storefront at 39 Avenue C, and I started doing syringe litter pickup in the community in the East River Park, Tompkins Square, and the playgrounds, which leads me to just a little bit of syringe cleanup that we did this month. In our records, we picked up 2,137 discarded syringes in the Lower East Side this month. So there really is a need, and COVID has driven this up some. I know when I'd emailed Susan, she had said Parks was interested in a kiosk as well. And so I wanted to touch on the fact that prior to my moving to Housing Works, and I've worked in the Lower East Side for a very long time, I had a hiatus in the Bronx for several years. I'm back on the Lower East Side. But part of the work I was doing in the Bronx was I worked with the New York City Department of Health, Mental Health, Parks, NYPD about putting kiosks in the Bronx parks, because I don't remember if people recall a few years ago, there were articles about 60,000 syringes found in St. Mary's Park. So we put 60 kiosks in the parks and in over 16 parks in the Bronx, and made it a successful program. I also created what was called the SORT team, which was the Syringe Outreach Response Team, where I created positions for full-time and 5 part-time outreach workers to go into the community, sweeping the parks and playgrounds and the neighborhood streets for syringes. And we do something similar on a much smaller basis because I have a small team out of the Housing Works on 9th Street and Avenue D location where we work. But having kiosks has proven, as we've seen in other states and we saw in Washington Heights and in the Bronx, to provide safety for the community. It gives people access for safe disposal around the clock. One of the things that we do is, because we pass through Tompkins Square as part of our regular outreach, is there's a few regular people that we provide services to that we've almost made ambassadors of safety, if you will, that we give sharps containers to that collect used sharps from the community which they inject with and give us the filled sharps containers in exchange for new empty ones. So kiosks are really, a part of the safety solution for the community. And that's something that we have the bandwidth and we have the infrastructure to provide. We would service them, we would maintain them. I'm proposing to put one in front of our location on 9th Street and Avenue D. But Susan had said someone from Parks was interested as well. I could be in touch with them and we could take care of service the one there, since we're only a few blocks away and we have experience dealing with biohazard waste. So I think this would really be something very beneficial for the neighborhood as a whole. So if anyone has anything, and also my supervisor, Max Sepulveda, is on the call as well. If there's anything you would like to add that I've forgotten, or if there are any questions, I'd be happy to answer them.
Yes, I wanted to add that the installation, maintenance, and repairs of these boxes, they all are part of the work that we will do as an organization and also as a program to wherever these boxes are installed. The boxes, they are at no cost to anyone that is interested in having these boxes. They could be installed at private properties if people find that convenient to their constituents, or they can be placed in parks or other undisclosed locations if people want to. We can train whoever is interested in knowing how to. We have, for example, other stakeholders that, for example, are interested in having kiosk box, but they don't want necessarily people coming into their property. So what they do is that they deploy people out of the community, and then they basically dispose of them into the kiosk box, and we go and we maintain them. We work with some SROs in some locations, and they also allow us to basically come in, maintain and clean the boxes, and basically provide them with ongoing training to their staff and to their constituents as needed. Susan, I believe you had a question.
I'll wait for May to start calling on people.
Okay, so yeah, Susan.
Yeah, I wanted to just say on the Tompkins Square Park, the containers there are replacement containers. Parks had containers there for years. They fell apart. They are now getting new ones, and they're going to, they were supposed to have contacted you, I'll make sure they did, about maintaining and emptying them, but they're not new, they're replacement, and Parks is actually installing the containers.
Excellent,
And
thank you.
I will just add one more thing. The discarded needles in Tompkins Square Park is increasing every day, and it's just really a horrible problem. So, the work that you're doing there with that is very necessary and appreciated.
Thank you, Susan.
What did you say? You already, well, there's going to be one in front of your organization, your facility on East 9th Street, but the one in Tompkins Square Park, that's also going to be a done deal?
That is just a replacement. Parks has had containers there for many years.
Okay.
It's just a replacement of ones that fell apart.
Okay, and then Housing Works is the one who maintains it?
Will be,
Yeah,
yes.
one,
Okay.
yes.
Okay. Any other questions, or should we be looking for other locations? Wait, there are questions. First one is Larissa and then Thomas.
Hi, I just wanted to find out how frequently you're checking the boxes, replacing them, sweeping around for needles that may not have quite made it into the container?
Well, we have an outreach team that's out 5 days a week. So they would be, I'm sure they'd be passing by the sharps container that's going to be in front of our location. We'll definitely get a feel for how often it's going to need to be changed, but it can be, we can look at it daily even to see how it is filling and get an idea for how often we're going to need to service it as that comes.
Yeah,
But
'cause
we're,
there's
I
a
mean,
huge uptick. I see them everywhere around the Lower East Side where I net on blocks that I've never seen them before. So really appreciate your services.
thank you.
Thank you.
Thomas put his hand down, I guess, so,
I'm still here.
oh, okay, Thomas.
Yes, so my question, I have two questions. How do you advertise this so that people know where to go for the kiosks? And also, just in perspective of schools, are any of these kiosks in proximity to schools? Like, has there been any issues with needles being found near schools? And I don't know if it's helpful to have them near schools, or is there like a certain kind of distance that you maintain from public places where children are at?
And we haven't put or proposed any near schools per se. It's basically been by word of mouth, which is how we were doing this in the Bronx as well. We'd talk to the people who were using in the community that we're doing outreach to and letting them know, and also saying like, hey, if there's anyone else that you see using here, please let them know that there's a safe place for disposal that'll make it safer for everyone else. And also let people know that while you're going to dispose of biohazard waste in there, there's an agreement with the police that they're not going to target you or harass you because you're doing something that's safer for the whole community, which was one of the things that we found initially when installing them in the Bronx. There was some hesitancy to use them initially because people were worried like, well, if I'm going somewhere to dispose of something that I've used for an illegal purpose, I might get targeted and I may still have something on my person that I'm not allowed to carry. And, rest assured, there was actually a 148th and street where one of the busiest ones were. There were police just down the street regularly because there's a high gang activity place, and they encouraged people to please use it because that was right next to answer your first question, that was right next to a playground and a school. That's not where we're proposing it near us. So.
Part of the strategy also when these boxes are installed is to deploy our staff around the parameters where the boxes are, to basically advertise to where the locations are and to make sure to make the police aware just in case they go around seeing any users, and they can also promote the use on the disposal of sharps.
Okay, thanks.
Okay, Deborah? Did you have a question, Deborah, or are you putting your hand down?
No, I put my hand down. I'm good. Thank you.
Okay, all right.
Thank you.
So does any of this, at some point, are you asking, what are you asking us to do? Do you need like a support or a letter or not, or are you just letting us know?
Well, just being a community-based organization, I think it's so important and to work with the community board and let the community board know what's going on in the neighborhood. Good, I mean, it's part of being a good neighbor. Also, having worked with the Lower East Side when in 1992, when we were on Avenue C, I used to attend community board meetings back then with Community Board 3, and actually applied to be on the community board, I think in 1995. But so I think community boards are so important, and I'm sure that you've discussed the increase of street drug use in the community as a concern. And Max and I wanted to come here to let you know, like, as people that are working with the people that I'm sure you've been concerned about, to let you know we're here to help provide some solutions. And also programs like ours are like the biggest resource into abstinence-based treatment. And we offer a lot of things other than sterile syringes and things of that nature.
So to answer the question, we don't need a resolution.
No. No, we're just looking for some support and to let you know we're here. And also, if there's any people you know, because if you're living in today's modern world, everyone on this call probably needs someone that can access some of our services. So let you know, we're at 743, 749 East 9th Street from 9 a.m. to 6 p.m. Monday through Friday. You know, and we have all kinds of harm reduction services, from the lock zone to access to treatment and care.
Okay, that's wonderful then. Okay, just checking.
Great. Thank you.
Okay, thank you very much. Okay, so we're on to our next item, which is we have Goddard Riverside Housing Works and Community Access. And I know there's a group of people from each organization. So what we're going to do is each organization is going to give a short presentation about the services they're providing. And I think the goal of this is to have some kind of a coordination of services in the end for, homeless, because there's a lot of lack of coordination. So, and I think Susan has particularly experienced it or seen it, when, people don't know what the other is doing.
Well, I will say Jenny and I talk about it all the time, and a lot of the ideas are from her. So maybe it would be good to start with Goddard. Would that be okay?
Sure.
Hi, everyone. I'm Jenny. I was going to say Susan could probably do my spiel on what Goddard Outreach does. I am the Director of Homeless Outreach for Goddard Riverside. I am overseeing our uptown teams. That's the Upper East and West Side of Manhattan, our night and evening teams and weekend teams, and our downtown team that serves 23rd Street and below, river to river. Alyssa Wrinkle is the Program Director for the downtown team. Did a good wave right there. But so just to talk to you a little bit about what our services are, we are part of the Manhattan Outreach Consortium, MOC for short, and it's 3 agencies that bring up the consortium: Breaking Ground, that serves the Midtown area, CUCS, that serves the Harlem Uptown area, and then Goddard's Uptown team and our team. CUCS is our lead agency, and we're city contracted to provide street outreach services for all of Manhattan. Just the street level, BRC has the subways. We work with the 311 system. So if you ever put in a call saying that there's a homeless person in need of services, it's our teams that are going out within the hour to engage someone. We work with local precincts, we work with community boards, and then we also have a lot of different neighborhood groups that we work with. We have a lot of referrals that come through just to make sure that we're meeting everybody that we're seeing out, meeting folks that sometimes are hard to find outside, but know to be street homeless. So we work with the Coalition for the Homeless. We work with Beth Israel and Bellevue, Barry Mission, The Door is one referral source for us. So agencies, where they're also seeing street homeless individuals, but we might not be seeing them on the street. We use a housing first harm reduction model, which means we want to quickly get someone off the street and into housing. Harm reduction, which I'm sure Van Asher can talk more about, but we are, wanting to ensure that we're giving, terms of substance use, of course, Narcan and things like that, but also in mental health and medical, that we're trying to, make sure that the person is safe and then willing to kind of work on whatever additional services that they may need. So our teams, we have team members that start at 5:30 in the morning, and they're going out and they're combing the streets looking for folks to engage towards services. So they start at 5:30 because people are still bedded down, not moving around the city, engaging, seeing, firsthand, do you want to go inside right now? If it's right now, we can offer shelter or drop-in services. But if they're willing to give us a little more information and they're eligible, we can work on stabilization beds or safe havens. In order for someone to go to a safe haven, they need to have verification that they've been street homeless for 9 out of 24 months. So that one might take a little bit longer. However, downtown team has been fantastic and can get people in pretty quickly. And we've been getting people inside within a day if we have that verification. So the teams are, also checking out locations. Susan will email me and say, hey, your team, look out for this location, and we'll send out our teams and go check on it, engage folks at that area. And then we have our day teams. Early morning carries a caseload as well as their day team, where it's kind of that dual role of outreaching folks and doing case management. And so our case management services, we are trying to work, the end goal is always permanent housing, and working on getting a housing packet together in order for supportive housing or any of the vouchers that are coming out. And so we're doing psychosocials, psych evals, getting identification for folks that might not have it, getting income turned on. And that's a whole story because that's a collaboration with HRA as well as medical appointments and psych. So our teams also have a street medical team that are just the most amazing folks I've ever met, that are going out engaging folks that might be resistant to or nervous about going to traditional outpatient care. So they're doing diabetes management or wrapping legs that have edema on the streets. And the goal is always to kind of get someone towards traditional outpatient care. And then we also have psychiatrists that work with clients on if they're willing to do medications, just general therapy, or doing evaluations for the purposes of getting a supportive housing application. So what I said before is, we want to quickly get someone off the street. We work with, the safe havens, which are smaller shelter settings and low threshold. So if someone, is hesitant into going to shelter, an example would be that, you have to sign for your bed at 10 p.m. every night, or you will be discharged and have to go back to the kind of main assessment shelter. For safe havens, they have 3 days to return, which is kind of much easier for our folks to return to. And then there's also case management that'll help with the housing packets, and we work towards permanent housing. Does anyone have any questions for me? Because I can also talk about locations. Would that be helpful? May, you're muted.
Yeah, why don't we hear all the presentations first, and then we will do questions and answers. And also, I don't know if the three of you have specifically talked about a proposal, or maybe this is something we're discussing now.
So
Or, if it is, you should present on that. If not, then we can do questions and answers and more discussion.
Okay. So our teams are, also outreach workers. So we're going out, engaging folks. We have a lot of areas that we consider hotspots, or, no areas that we, have historically had homeless folks, like Tompkins Square Park, but there are areas that we're also seeing increases. Susan and I had really been speaking specifically about SDR Park, because over the years it is, we've always had homeless folks there. But I think in terms of what I've been seeing is that in conjunction with drug use, it has become a lot more unsafe to even outreach, to be honest with you. We were doing a COVID drive, giving vaccinations, and we're kind of pushed out of the park by someone that was trying to sell drugs. There are a lot of times that our team members, we have to go out with 3 people. It's usually just a pair. But for SDR Park, it has to be 3 people, just because there's a lot of intensity, whether if someone's on K2 or whatever else that they're on, crack use. it just becomes kind of more of an escalated situation. And we've been really, working on we've done joint ops with harm reduction programs. And I think one of the things that we're also seeing is that, programming for our folks has kind of decreased since COVID. And the idea is there a way for, community access or to maybe have their day programs, in the park, or just what it feels like is that we need to be a little more creative in what we're doing in terms of SDR Park. So the idea was for us to kind of come together and see what learn about the programs first, and then see what we can do. So
Okay.
that's,
Okay, great. So can we hear from, does it make sense to hear from community access next?
Yeah.
Hi, my name is Ganit from Community Access, and I'm here with Beth also. I'm the director of the Community Health Division, which oversees all of our treatment programs. And Beth is the director of our homeless mobile teams, which we operate mainly in the Bronx and North Manhattan with the our homeless teams, mobile teams. We do have one treatment program in the CB3 area, which is a PROS program, which is a psych rehab program. And it's located on East 2nd Street. And of course, we have about 10 different housing sites, 9 or 10 different housing sites in this around CB3 areas. I would love to speak to Jenny more and the Goddard people, or Goddard, or I have no idea how you say your name. And to kind of build collaboration. We have been working very closely with our mobile teams and the outreach teams in different areas in the city. And we definitely want to enhance our presence in the Lower East Side and East Village as well. So that's definitely something that we can brainstorm. We do service in all of our programs, even if they are not designated to the homeless population. All of our programs service people that are homeless or living or even on the streets, and including our PROS program on East 2nd Street. That's definitely something we'll be interested in exploring more with you, Jenny, and your teams, and see how we can create something that, assist both, all of us and the community.
Okay. Okay, so next let's hear from Housing Works. Who's going to speak for them? We have a few people here.
I was going to say, I can just touch on the fact, I know our outreach team goes through the park almost daily, and the majority of people that we're seeing in the park are street homeless and using things like K2 and aren't really necessarily our target population, but we'll do naloxone trainings and make referrals to our health center. So I mean, we pass through the park almost daily on the way to really other locations where we have more of a targeted outreach, reaching towards like people who inject substances.
Could you mention where that is?
Oh no, towards Sarah D. Roosevelt Park. What we're just talking about. The park.
Are there other programs? Well, I know that Housing Works has other programs in the East Village. Could you talk about some of the other programming you do?
Oh, sure. I mean, we have a full medical center. So we can, one of the things that we do out of our harm reduction program is we do offer testing for HIV and hepatitis C. If anyone is positive, we can offer treatment. We can bring people in and get RNA confirmatory testing same day and start treatment depending on, and we have adult day health services. We offer, I mean, we offer a lot of services. Housing Works, the Keith Cylar building on 9th and D is also residential AIDS housing. And if someone qualifies, you know, there is permanent housing for people that qualify for housing there as well. So I mean, we have a full medical floor. We have buprenorphine, which is medication that can be used to treat opioid use disorder, where people, if someone comes in and they have a dependency on an opioid, they can start taking this, which is a partial antagonist. So it can block other opioids from the receptor, and they can take it as someone would take any other medication and kind of go about their ordinary lives. So those are some of the things that we're doing out of the East Village location.
Additionally, at that location, we also have a peer training program that allows people to get basic training to be able to get a stipend work. And what we found when we're working with the population is that sometimes they just need to know a way out from wherever they are, and sometimes learning a soft skill allow them to move into a sort of like a stipend position, and then from that stipend position they can generally move into part of full-time employment if that's something that they have desired or do develop the skill. When our workers go out into the community, they bring all different type of program promotions that are actually are distributed among the community so that people know what kind of services will be available there when they come to the site. And there are different ways that people can engage in services. They can just walk in, or they can make appointments. All our information generally brings forms that people can connect with program services.
And additionally, starting next week, we're going to have an auricular acupuncturist on site that can treat people with opioid use disorder for on-site detox on demand, and it also helps with PTSD and stress management.
And our clinic also provides mental health services and also has a way of connecting people to OASIS treatment as needed.
And your services are specifically for people with HIV?
No, the clinic services are for both HIV positive and negatives.
Okay.
Are there income restrictions?
No, our clinic is a federally qualified health center, which allows participants to receive care, medical care, and mental health services at low or no cost, depending on the situation of the individual. We also have health home services, which is intensive case management services for those who might need assistance in being connected with social services. We assist them into getting insurance. We assist them into applying for further housing. One of the hurdles that we find is that many individuals who happen to be HIV negatives, their finding housing is a hurdle because there is not that many benefits available for people who are not HIV positive. So we assist them into getting 2010E or Section 8 or any other services that they might be available to.
Oh, okay. So before we go into the discussion about, coordination of services, does anyone in the committee have any questions about for the three, just about the services that they provide or what they're doing right now? Raise your hand, please, if you do. Well, I don't see any hands raised. So it looks like we could, start.
Well, we do have Alicia's hand raised.
Alicia's hand is raised. Oh, Alicia, hi. Alicia Lewis Coleman.
Yeah, hi. Can you hear me?
Yes.
Okay, so my question is, I noticed that many people that are on the street homeless, they tend to not have proper identification or other services. Are there any of the agencies here present that would help in assisting them to get proper identification for them to further their insurance? Because many of them, they lose their wallets, they lose their IDs, their medical insurances and things like that. Do you keep a record for them? Like take a copy of it, if they do have photo ID, take a copy of it in case they do lose their IDs or anything of that sort? Because I see that that is something that is needed right now with the street homeless.
So I could say that anyone who have needs of that sort, case management is usually the best option. And then when someone enrolls in case management, there is a chart that is developed for the individual, and we suggest people to keep copies of their documents at the record if they want to. So in case something gets lost, it can be easily replaced. So it's a matter of connecting people to social services to be able to get those other services that would be needed.
So it's connected to somebody outside of you, is what you're saying.
It's connecting the person from the street into a program that will be able to provide comprehensive services.
And our
Oh, okay.
teams provide case management services to anyone on the street. And we would be able to easily help with IDs and things like that.
Oh, okay.
I have a
Okay.
question.
Susan, yes.
So all of this leads to I guess my biggest issue. So say somebody is on case management at Housing Works and they're homeless and on the street. And a Goddard outreach worker encounters this person on the street and doesn't have this information. So they're trying to engage with this person. Where is, it seems like we have all these different case managements and different records in totally different separate places. And I don't understand how that works. I know the city a few years ago finally created a hub where some information is supposed to reside, but I think that's just through city contracts, like homeless outreach who has a contract, or mental health workers who are working under the city, and that information goes there. So you might have some information there, then you have some other information at Housing Works, and I assume other information on case management someplace else. And is that the situation? If it is, it sounds like a pretty inefficient situation. And what are the experts, the providers' thoughts about this? And I guess we should start with Jenny.
Since we've never talked about this before. So we do ask our clients if they are working with other providers. We get consents done. So, we do referrals to Housing Works or Community Access. The PROS program has been fantastic. So it's basically, I think, for my side of things, we can ask the questions. I don't know if the other providers are. I'm sure they are, because we want to know what the supports that our clients have. Oh, I forgot what I was going to say. I had a point. But I think that there are times, I know from some of our clients, that might be engaged from so many people that they might forget their case manager with our team's name, or say like they're working with Breaking Ground when they're working with Goddard. And so even internally, there's always confusion, right? Because our clients are being engaged by so many people that it might get missed, right? If they go over to community, to Housing Works, you know, and say, I need services, and say, no, I'm not working with anyone, but like their case manager might have been there the next day. So yes, there are silos for sure. And I think it has been a difficult question on how to handle it, you know, in terms of like, you know, HIPAA, right? And being able to ascertain the information from our clients as well. I don't have an answer for you, Susan.
I thought you were going to resolve the problem.
So you have clients, but they could be going with using other service providers and from more than one organization, more than one provider, but you can't necessarily know who and what it all is.
Yeah, I mean, Alyssa, what would you say? Like, I would say that on average, our clients have 3 providers. I feel like can feel like, you know, methadone program. You know, we're doing referrals for more intensive case management services. So there are a lot of teams, but I think it's also how many people are engaging that person. Let's say they're outside at SDR Park. I think the main thing is not knowing who else is engaging them and giving information.
Is it allowed for, say, the providers such as the ones here, is it allowed for them to be able to network about people they're seeing and to see if you're seeing some of the same people? Because I know the information could be very valuable that one may have and not the other. I mean, we saw that in SDR Park with, I won't go into that. I'll get us too upset. But is it, you know, are you breaking any regulations if you were to try and network and share information about people you're seeing?
The answer is not necessarily. It really depends on the participant. It really depends on the client, what the client knows and would like to reveal about themselves and their services. We can communicate among each other through HIPAA regulations. We can communicate with each other through linkage agreements. We can communicate with each other different ways, but the issue is that many times the client himself or herself doesn't know exactly what program they are connected to or who is their case manager. And I think I would like to say that also part of the issue is that the social services system is pretty disconnected in terms of, you know, if there would be a system where you just punch someone's number or someone's name and it tells you all the services the person will be connected to, that would be the perfect case scenario. But that's not really what happens. There is not a system that connects all those dots. And, you know, HRA generally try to do something like that, but it requires, it depends on the center, it depends on the system, how that information is connected. What I think will have worked for us in a way, you know, somewhat has been to making sure that we get a lot of information from the participant, as much information as possible, assess what are the resources available, because if, for example, someone is homeless and has absolutely no resources in place, we know that we need to start from scratch. And then we need to reach out to the other organizations that provide additional services that we might not provide to be able to make those connections, and then we know. But if the person has already started a process somewhere else, it's a little bit difficult to identify how that would be. And also sometimes clients do not want their information to be known by everybody.
Does anyone have any questions? Committee members? Ideas?
Could we maybe ask Community Access if they had
Yeah,
any ideas on this?
we can share some what we try to do. So regarding the street homeless, we've been trying for a few years to work with DHS to allow us to have access to Street Smart and all of those portals that DHS runs. So we would be able to find out people, be able to kind of work more collaborative with the outreach teams. DHS has been blocking it for many years because of what they call legal reasons. So we are really resorted to work more personally. So if we know Ginny and we know people from COCS and we just work like that. So that's kind of how we resorted to that. We also use, of course, Rio, Psyches, Healthix, to find who works with the people that we work with. And we don't have the ability to break the ceiling, as they call it. Only emergency rooms have that. So our access may be limited if people did not sign a release of information for us for those portals. But if they are deemed to be at high risk, according to Psyche's scoring, we may be able to have some access to, or Psyche's may identify them as people that high users or high risk, and then we have some abilities to find who are the people that work with our individuals, when were they last in the emergency room, what medication they take, and all of those kind of things. Some programs the city allows access to alerts, and most programs are not. So again, it's not even. So these are the things that we try to everyone to really encourage them to sign release of information with all of this. But as everybody will tell you, it's not always that easy. So that's how we try to work with people. During COVID, we were able to obtain more verbal agreements, with everybody. So it was a little bit easier, but I think we are resorting back. I think DOH has resorted back to they need a wet signature, as they call it, for all those consents. So that's how we try to work around it. It's very, very confusing to the individuals sometimes because they're surrounded by so many people, and then the system kind of building it instead of supporting current programs. They're putting more and more programs around the same people, which is very, we have a lot of problems with it, and I'm sure everybody else that works in the field has a problem with that. So that's about how we're trying to get around those issues.
So is there a long-term effort to get DHS to take this other approach that you are talking about?
They won't. We've tried. We've tried talking to them.
We tried since we opened our Shelter Act team that Beth still is the director of that, which was in, Beth, when was it, 1918?
Close to 4 years ago, but it feels like 1918.
2018, yeah, it feels like 100 years ago. But we're not giving up. We continue to talk to them. They are putting the legal barriers. But we find that just working with the outreach teams is the best. We work very closely with BRC and COCS and some of Goddard, not a lot because we don't cross roads that much. But that's really what we are trying to do. And it's not, there's a way to talk about people without really talking, you know what I mean? It's like, there's a way to, and we're all very open to that. We do it with people if we don't have the release of information and, but it is a barrier for all of us, that's for sure.
You brought up HealthX, which I'm not sure if everyone's familiar. Do you mind just going into that, explaining that a little bit? I can do it, but I think you might, since you're using it, it might be helpful.
So I don't know if you're familiar with Psyches, and Psyches is really only for people that have Medicaid. And people even that have Medicare, Medicaid, because Medicare is a primary, most and which means that the first payer for all treatments and everything, many times you can't find a lot of things in psyches, which is run by Office of Mental Health or Office of Department of Health. I'm not sure, but I think Office of Mental Health from Albany. And that gives a lot of information of the last 5 years of treatment. And it also mentioned all of the providers that are billing Medicaid or managed care Medicaid. Recently they agreed to add, by the way, the IMT teams, which are not billing teams, but it's very exciting because so now they're going to add the all IMT teams on that psyches. So it will give additional information, even that the program is not billing for those services. HealthX is kind of the same idea. You can see all the notes and all the blood test results and any other test results from every medical provider. And it's not only Medicaid, it's for all insurances that, especially like hospital hubs that signed up with that, agreed to put their information within that. You need, of course, again, a person to sign a release of information to allow us to have a peek into the medical records on both portals. RIOS is used a lot by our care coordinators, and that also gives actually a great overlook for other providers, status of treatments, and all of that. But not everybody has access to it.
Okay, Susan, you had a question?
Yeah, so it seems to me like a lot is dependent on getting information or motivation from people. And the ones who I guess would need help the most are probably the ones least likely either motivated or able to make the decisions to do this. And if there was some way that the community board could help in supporting a coordination process, is there any way that we could do that? Or is there any ideas on the part of the providers here for more formalizing this? Because I've heard a lot about, informal coordinations, but it seems like it's often dependent on, certain people being there and having the time and ability to do that. So is there some way we could support this by convening something or getting a group to convene something? Or is there a way that providers could more formally do this?
One of the thought that, oh, you want me to raise my hand? Oh, Beth, go.
This is my first community board meeting. I don't know if I'm supposed to raise my hand. I have a question that I think would help this conversation. The folks that you guys are seeing who seem to be the highest need, people experiencing homelessness, do community members ever get to know their names or anything about them? Or do you guys most frequently see them as visual, like I recognize this person, but I don't really know their name?
Susan is an honorary outreach worker. Yes, they're getting to know community members for sure.
But most,
this isn't a, I'm sorry.
I was gonna say generally, sometimes we do get this information, particularly on someone that's very in need. But there's also, I'd say most of the time, it's people we're seeing on the street that we don't know.
I'm gonna think about it, but that was my question. Thank you.
Yeah, so we still do want to know if there's some kind of formalized way it could be done, or is it something that, it's like the city has to mandate you to do it or fund you to do it, or, because coordination, look, I know it requires more resources too, and more like manpower and more effort. It's not easily done.
Sorry. I actually
go
for
ahead.
years were thinking, and Goddard people can tell me if they actually have access to CARES, but DHS has amazing system that called CARES, CAIRS, and they're really again limiting who has access, who can look at that, what can be looked at, and all of that. And this is actually a system that is connected to HRA and Social Security. Like if you really have in-depth ability to look at it. And I, for years, wondering when they're going to open it up to assist with kind of coordinating and working with people that are so transient and don't have a lot of documents and all of that. It's a lot of it can be digged in CARES. But I don't know, Jenny, if you and your team have access to that and what your experience with that. But it's huge, huge tool that I think underutilized outside of shelters.
Yes, we have CARES and we have Street Smarts, which is actually specific to the outreach teams. It works. And it's helpful to basically know what other outreach teams are out there and if a person's income is turned on, what vouchers the person may be available for. But in terms of coordination, I think it's mostly between the outreach teams is how it works. And it is helpful in that aspect. And just to kind of answer Susan's question, which is a large one, I think it's something that we have to think about, right? Because we have 3 providers here. We have the outreach team, we have community access, and we have Housing Works. But I think also specifically also to this area, there are so many different social service agencies and even just community partners that know the clients that I don't know necessarily if our partnership would help out because of so many things. Like I think about, the importance of the food vendors at Tompkins Square Park, for example. How many of them are engaging our folks at all times, or the other small, agencies that are going through the park doing harm reduction. So, do our teams refer to both of these programs? Absolutely, in terms of Housing Works and community access. So I just need to kind of think on my end too, what this kind of coordination would look like and what would make sense for our teams. For me, at least, what I was really thinking about was SDR Park and could there be some sort of collaboration in getting programming outside, especially during this weather? There are so many people in need in that park, and it's also, just a lot of drug use there that it's hard to get programming. Thinking about hearing about the peer support program, and training, how fantastic it could be for a lot of the clients there. But I don't know if necessarily because of the substance use, would they go over to 9th Street? It's more of kind of going to them, learning about what the programming is and seeing if you can get buy-in. There are volunteers and people that work at SDR Park that will go around and hand people like a broom and trash bag, and clients will help clean up because they do care about it. And I think it's more of like getting that programming out there to them instead of expecting that we're going to have them come to us.
So are you suggesting like Housing Works might be able to do that in SDR Park?
I wasn't kind of saying specifically. I'm just wondering, I think learning about each other's programs would help to see if that's something that could be possible.
Yeah. So I think that it all depends on what is the service that is needed. Housing Works can do to the extent of what is the need of the individual. We deploy people on a daily basis from the harm reduction program to go and engage people in services either where they are, and that's done through peer delivery service exchange services. And when that happens, we generally go engage individuals, bring them program information, and enroll them in the program. And then on a regular basis, when we do our outreach, we connect with them to basically be able to reroute them back into the site. Because the idea is not really to just leave the individuals out in the community, but really reroute them back into the site. There is another harm reduction program that I oversee on 37 and 8th, and at PHP, for example, there is a bigger space. We have a drop-in service, right? And the drop-in is intended to, when the outreach team goes out, they bring them news about this drop-in area, where you can take a shower, where you can have some snacks, where you can watch TV, where you can do something that looks very simple, but is very significant for someone that has been homeless for years. So we bring that information, and then we let them know where they can come and get it. And then they come into the site, and that's one way of basically engaging them. Providing services on the street is kind of limited because it all depends on what is going on there. We could provide HIV testing, we could provide education, we could provide potentially case management, like Jenny's saying, that happens, and some other services can happen, but the core services like care coordination, for that, the individual needs to go to a center, need to go somewhere, need to go to a place where that would happen. More intensive case management, mental health services, they need to go into a place to be able to connect to those services. And that is a little bit more complicated. But I think that as an organization, we can definitely commit to have more of a presence out in the community if it's needed. We do not have any problem doing that. That's part of what we do anyway. And whatever the individuals that we engage that might be able to utilize our services, are more than welcome to really engage and deal with them. But it's really very dependent on the individual that is found on the street.
Oh, I have to raise my hand. I haven't done it since school. Can I say something?
Yeah. So
don't know
okay.
what
So
the rules are.
let me clarify this hand raising thing. So
Yeah.
there's a lot. There's like at least 3 or 4 people who are presenting right now. Seems mainly 4 or 5. So if you are contributing to this presentation, just speak up. But the others need to raise their hand. Okay, go ahead.
I just wanted to mention that maybe what we can start to talk about is the city is adding 20 IMT teams around the city. And I think that the collaboration between mobile teams, homeless mobile teams, which are treatment-based teams, and outreach team can really generate a very good work together, whereas the site-based team are so regulated into provide services in certain way and to who we, so that's maybe something we actually have a very successful collaboration uptown with CUCS, with street people that we combined the 2 efforts. So maybe that's something we can talk more about, and we are in the process of opening 4 more teams. By January, we'll have 4 more IMT teams, and we can really collaborate more in that. Right now, we have 2 homeless teams, actually 3 teams for homeless, but 2 of them are actually treatment. But I do think that the collaboration between mobile homeless teams for that treatment based with the outreach can really will be beneficial for the people we serve and for each other, because we can support each other in kind of same effort. So that's something to think about.
Plus, I have 2 people waiting for the IMT teams to open up. So that would be great.
I'm sorry, what is IMT?
Beth has a prepared spiel for that. Let's hear Beth.
I mean, just
Right,
what does it stand for?
Intensive mobile treatment, and it's the highest level of outpatient care available in the city. So it's a new model. Only a few years ago it opened, and the caseloads are extremely small. The criteria threshold is to work with folks who have the most systems contact, incarcerations, homelessness, hospitalizations, people that every other traditional model of service has not been able to meet their needs. So it's, the highest needs people living in the city. And the model started in 2015 as a pilot program, and partially in response to the increase in visible homelessness in the city here in the past couple of years. The city has moved from having 8 teams to adding 20 and then 5 more by 2023.
Okay, so what's our next step here?
Thomas has his hand up.
Thomas?
Yeah, you've spoken a bit to what I was going to inquire about, like, what are the mobile options that are available? I'm curious, would it be possible to, since there is funding post-COVID, would it be possible to have some sort of a mobile unit that each of your organizations could have representation in? Kind of like to triage, maybe, it might not have all of the bells and whistles of the IMT mobile unit, but something because I heard the discussion saying that it's difficult to bring people over to 9th Street, but maybe since we're talking so much about the Roosevelt Park, would that be an option to actually meet a need right now, especially since the weather is still fairly nice outside?
Okay.
That's doable. That's very doable.
As far as community access, the treatment program that we have is a site-based program. So it's not a program that, and it's also can only service according to regulation with people that sign in and officially enrolled in the program. So it's very difficult for us to kind of expand beyond that because all of the regulation. But I would definitely would like to speak to Goddard and see what we can do, even like by starting to go in. I don't really know. I don't want to say anything, but we have the director there and the team, and we can definitely meet and discuss what do they see the need and how we can start maybe to outreach people for, encourage them maybe to come to an indoor program or something like that. Our program at the East Village is open door in a sense that people can come from the community. We had a lot of people just stepping in, asking questions, and then applying and applying, registering and starting to receive service. I mean, that's what we can do, but we cannot just go out and service people that are not involved in our programs because of a million different reasons. Yeah.
Okay, Susan, you had a question?
Yeah, no, not a question. I just wanted to give some sense of what's going on to board members and other people on. I'm not sure everybody kind of realizes how the city's dealing with this. So you may have read the article, I think yesterday or a day before, in E.V. Grieve about Tompkins Square Park. So Tompkins Square Park is, since COVID, and I don't know why, all the reasons, but I suspect that a lot of it is not, I'm going to say simply homelessness, but certainly a lot of drug use and mental health problems. So you may have seen what's going on in Tompkins Square Park. We have these huge encampments and huge people living there, and it's not good for the community. It's terrible for the community. It's terrible for the people involved who are living there. So how does the city deal with this? They go in, they take all the possessions, they move them over to another spot, they rope it off. This is at both SDR Park and Tompkins. They rope it off for a couple of days, and that's how we're taking care of our homeless, mental health, and drug use programs. They did not coordinate with DHS. They did not coordinate with the police even. And something, it really, really, really has to change, both for the sake of people who are living on the street and for other people, housed people in the community. And, I just feel like if nothing else, at some point, the board should make some kind of stronger statement about this and about the care and the policies. And, I certainly want would like our providers, we're very much a family in the Lower East Side or East Village, to come up with some ways and think outside the box on what we can try and promote, because it is really terrible. Sorry.
Thank you, Susan.
So right, there's, I hear about all these things in SDR Park, actually, and I hear from the board members, things that, and then there's the thing about, roping. Just what you were talking about, Susan, is not just, and what we're talking about here, the providers coordinating services, it's a little bit like two different things. So I'm wondering if we need to also, in addition to this discussion we're having about coordinating with services, do we need to, that was the police department and the parks
No,
department who did that,
it's
right?
not the police. It was
Oh.
not the police. It was the parks. And I'm not, they are coordinated, because if there was some other kind of effective method of working with the people, parks wouldn't be doing that. They're getting complaints and they don't know what else to do. That's the issue. So they're very, very connected. It's because there is no other action to take, and they feel like they need to do something.
So I think maybe a next step could be that Community Access Housing Works and Goddard can kind of get together on our own, dive maybe a little deeper into kind of what our programming is. We can talk, Goddard can talk more about like what we're seeing as the needs in the community, and kind of go from there. It just seems like it's not going to be solved overnight. And I think we need to understand one another's programs a bit more to kind of come up with what kind of collaboration could look like and what makes sense for our population.
And I also wanted to ask, so in terms of what happened at SDR and what happened at Tompkins Square, in spite of this situation, and, was there something else they should have done instead of what they did? And
There
do we need
is
to speak out about that?
nothing. There is nothing. I mean, Goddard and Housing Works and all those people go out there almost every day. Just doing that the way it's being done doesn't work. It doesn't work well enough. I certainly don't want to say, their work is very valuable, but it's not working well enough to solve this problem. So there needs to be another way to do it. I know at Penn Station, the city has contracted with Housing Works to work with another provider to do outreach and harm reduction together on the street or in the station. I don't know anything else about the program except that. Andrew Comey at Housing Works mentioned that to me. There's what I'm saying right now is it doesn't work. The city is not dealing with this issue because I don't think there's enough concern. And that's why I'm hoping that we can be a catalyst for the providers in our community to find a way to at least pilot something. And even if it's in SDR Park, which is probably the area that needs it the most. I saw Tati had her hand up.
I would also just say though, really quickly is, this is a big issue, and whether it's what's working or not for our teams, but there isn't enough supportive housing. That is a major thing. We can get people inside. Our retention rates are great. It's the fact that there isn't housing, but safe use areas, passing in New York would be great. I still will always say that I'd like to see wet housing, which is a place where folks can use inside safely, monitored by nurses. These are things that are more out of the box. I don't think that they should be considered out of the box because it's what needs to happen with what we're seeing in the community, but it seems to be, I haven't heard actually much about this moving forward, though safe use, I think I have areas I have heard is hopefully gonna go through, but I just want to put that's, you know, lots of major issues when it comes to trying to solve this.
Tati, your hand is no longer up. Does that mean you changed your mind?
No, I mean, Susan basically said there's nothing else that they can do. I was just wondering because I went by Tompkins and I noticed that it had been roped off, but then I saw like a tent right outside of Tompkins, right near where it was roped off. So I was just wondering, like, I mean, it seems like these folks just end up coming right back. Is that the case?
Yes.
Yeah, okay, yeah.
Yeah, I had a long talk with Parks today and I said, what's the objective? You know, how is this productive? And the truth is that people complain, so they must have some kind of action. And it's not that they even necessarily want to do it, think it's helpful. They don't know anything else to do. It's not that they're even trying to be mean. They just don't know anything else to do.
Just wanted to tag on to what Jenny said, that not only just access to supportive housing in general, but low threshold housing, that, you know, providers that are willing to accept people that maybe they don't have an active income yet, but we'll move you in and then we're going to work on getting you your income so you can start paying your rent, having flexibility in taking copies of vital records, that maybe somebody has a photocopy of a fax of a birth certificate from 15 years ago, but we can't get the original for whatever reason, and not having it be part of agency policy or property management company policy to see the original of a vital document, because that's what a lot of housing providers are requiring. Community access doesn't. Like Jenny was saying, like housing that's flexible on understanding that most folks that are using substances to cope with something and cope for a reason, and losing your housing because you're using drugs in the building is not going to long-term fix any of the problems that are coming up in that conversation. So like, I'm loving that this is happening, and the opportunity to be connecting with Goddard and Housing Works in a way that I haven't had an opportunity to do before. But it is kind of for me, it feels like the very start of a conversation. I'm personally very Bronx-based, you know, and I'm learning about this neighborhood's needs. So I'm looking forward to continuing it.
Okay, that sounds great. So how can we continue this? Should we think about focusing on an area like a park, or there's a, or is it more the health, since there are health providers here? Or somebody talked about, you know, what they need is like a place to go to, you know.
I'm not sure we're there yet to even kind of focus on a place. I think the next step would just be providers talking offline.
I think the one thing the board can do is potentially reach out to city council and basically bring these concerns to city council, because there might be an opportunity there to identify funds to be able to implement, you know, get creative about implementing different services in different formats, which is what we are really talking about. It's about really bringing services to where the population is, to be able to redirect them into more stable settings. And that requires different set of strategies and different set of resource reallocation. The conversation about overdose prevention centers or safe injection facilities is a conversation that is starting again from the city and the state perspective. So that's something that could happen. It's just that it's going to take a few months before it actually picks up or is actually being very concrete. But I think right now the needs that you guys have right at hand is something that, you know, because there is not really a system to handle what is happening out there, it's really making city council aware that some of these things some of these resources that are probably put in other areas might be probably beneficial to consider them at this particular issue.
So they are aware, and Jenny and I have tried working with the council in this area to do some kind of pilot. And I think something what you're talking about is more extensive and sounds great, but I think we would need sort of a formal proposal to get funds.
Okay.
Well, yeah, definitely.
So maybe, do you think maybe like in 2 months, one person at least could come back and tell us if there's been anything productive you've been able to come up with?
Susan, do you mean in terms of a proposal?
Or, you know, if the three, both either a proposal that we could support, or if there's some kind of less formal pilot program that the three providers might be able to try, you know, just to give us some an update if anything seems possible. So I saw a thumbs up.
A thumbs up from Max, right?
Was it 2? Well, then it was 2 thumbs up.
Okay. Okay. Well, we're talking about how do the others feel? Much.
Talking about providers or committee members?
Oh, providers, since you're asking them something. Jenny,
I think in 2 months we can kind of report back and see what we're thinking of.
okay. All right, so why don't, so do you want to maybe come back to a committee meeting in 2 months? Or is it just talking to Susan? We can, or, you know, we meet every month. That would be good. And then, you know, we could get feedback as well from a larger group. Well, we can, okay, so we meet every month, September, October, November. Okay, so, you know, we can tentatively put you in for November.
I'll take November. So we can give ourselves some time to to talk, to think about what we can do and what makes sense for this. We really need to get to know each other also, which is kind of, and what we each of us do and what our abilities and what are kind of things that we are limited with. So yeah.
Okay. All right, sounds good. Okay, so if there are no other comments or questions, we will close this agenda item. I don't see any other hands raised. Okay. So thank you very much.
Thank you.
Thank you.
Thank you.
Okay. Thank you, Jenny.
Thank you.
All right. So, okay, thank you. Okay, so our last agenda, I don't think we have anything, but our last item is CAB reports and CEC reports. I know Tati, you said you didn't go to a CEC meeting, but you will go to one in a week or 2.
Yep, next Thursday.
Okay, and there will be, Larissa, you did not go to any CAB meetings, but there were none, but there will be one soon.
There will be one, yes.
I went to the Beth Israel one, but Brad shared everything that he shared at the meeting that I went to. So there's nothing new to report.
Okay, wonderful.
I went
Okay,
to the
good.
MSBI one. Yeah.
Okay, all right, thank you. Okay, so, okay, so our next meeting will be in October. Ours, okay, before we close the meeting, is there any new business or old business? Or other things to discuss? Or you have questions to ask? I don't hear anything and I don't see any hands raised. So we will have the final roll call by Thomas.
Okay, May,
Yes, here.
Larissa,
Present.
David,
Present.
Eric didn't show up, right? No Eric? Shirley,
No, Eric.
Yes.
Deborah,
Present.
Tatiana,
Present.
Laura,
Present.
no Paul, Heidi,
Here.
and no Ricky, and no Carmen, right?
That is correct.
We are done.
Okay. All right. So we will see you. Okay, so full board will be on September 28th. And Susan or Alicia, do you know if it will be in person or virtual?
It is, everything this month is virtual. In case people are not aware, could I just give a short announcement, May?
Yes, you can.
So yesterday, the state legislature amended the open meeting law so that public bodies such as the community board can have virtual meetings until January 15th. So there were, I think, 2 or 3 in-person meetings this month. They've been changed to virtual, so all meetings this month are virtual. The Zoom links are on the website, and I should get an email out to all the board members announcing this tomorrow.
Okay, good. All right. Okay, thanks, Susan.
Okay, thank you.
Okay. All right. So we'll see you at the next meeting. Good.